welcome everybody. Hopefully you've all joined. I can see the participants are starting to log on. Welcome to the ESID Grand Rounds for the first one for 2024. We have a discussion today about transition, and the purpose of this webinar is really to launch a new set of transition guidelines for the transition of patients from pediatric to adult services for primary immune deficiency and autoinflammatory disease. And we're running today's webinar in collaboration with ERN RITA. We have developed guidelines as part of the ERN RITA working group in collaboration with ESID, and we'll be showing you some of that today. But before we go through and highlight the new guidelines, we are going to have a number of talks just to think about transition. And I'm delighted to welcome the panel members who've agreed to join today. So Nizar Malawi, who many of you know, is a pediatrician at the Necker Enfant Malade University Hospital in Paris. Nizar is going to moderate today. We have the team from Rotterdam with us. So Virgil Dam, who's the adult immunologist, Marianne van der Ent, who is the clinical nurse specialist working with the team, and then Amy Van Ass, who's one of the patients who's a user of Virgil's service. Welcome, Amy. We've also got Per Soler Palasan, who's a pediatrician and head of the Pediatric Infectious Diseases and Immunodeficiency Unit at the Vall d'Hebron University Hospital in Barcelona. And we have got Elizabeth Davis joining us, who is a clinical nurse specialist from the pediatric unit in Oxford, who has a specific interest in transition. So welcome to all the panel members. Thank you for joining today. And Nizar, I'll hand over to you.
Thank you very much, Siobhan. Thank you to all the speakers who agreed to participate to this grand round. Thank you to ESID and to Rita to host this webinar on this very important topic. And it's great to have all healthcare professionals gather and patients gather around the table. To start with this webinar, I'd like to share with you sharing my screen right now. Hopefully you can see my screen on the slide mode, I hope. Yeah, is it working?
Yeah, yes, we can see that. Thanks, Nizar.
Okay. Really short introduction on the topic of transition care. So it's really not a new topic as such. It has been defined at least 20 years ago as a lifelong process to meet chronically ill children's individual needs as they move from childhood to adulthood, in order to maximize lifelong functioning and potential through the provision of high quality, developmentally appropriate healthcare services, which I think is very important to continue uninterrupted as the individual moves from adolescence to childhood. And as you probably can see down on the slide, it is a process that takes time. Starts early in the pediatric care setting, but doesn't stop at the transfer, which is really the time point when a patient moves from the pediatric care setting to the adult care setting, and the transition continues a few years after the patient has moved to the adult setting. Why do we need transition care, really? So it's really there are many needs in order to a defined and coordinated pathway to guide patients towards the healthcare system, because teenagers might be lost to the system, might have many issues, including poor compliance with their treatment, potentially leading to irreversible organ damage, lowering their life expectancy, having sequelae and reduced quality of life, and at the end of the day has also implications in terms of healthcare and cost. It is vital to ensure easy access to essential healthcare and support during this period. And one of the very important things is to ensure that there is a bond of trust between patients and families and the teams on both pediatric and adult setting, and reassurance of patient and family are key. And I think that discussing as of today, this topic is really a cross-fertilizing benefit for both pediatric teams and adult teams. So, you know, in our field, in EIA and PIDs, we talk about newborn screening for severe T-cell lymphopenia and SCID. These colleagues who are used to discuss this with patients, for example, in cystic fibrosis, when they inform the parents of a young child or a young baby that their baby have such a disease, they mention to them two things. First is the diagnosis. The second is that at some point, the patient will turn 18, 19, and will need to move from the pediatric care to the adult care, which I think is quite important to mention as we move along to further newborn screening in our field. There are growing cohorts of patients because of thanks to improvements in survival, but also challenges in terms of modification of natural history, and the number of profile of comorbidities might not be as known as we get to know them in textbook. A classical image here is a matrix of how each of the trio, at least during the pediatric care setting, might move along age from, let's say, 12 years old to 22, 23, is really to help the youth, the patient, on the right side of the slide, to switch from a more passive, so to speak, attitude or receiving care to a more active and more proactive and supervising care. Whereas parents of the patient still have a role as well as the healthcare professionals, obviously. So there are many models of framework. This is something that has been published a few years ago in the British Journal of Medicine, with the patient at the center, with his or her clinical chart folder, and people in the background helping him or her navigating the healthcare system throughout the years. And for us as PID specialists, we work with many different colleagues, collaborators in the hospital, in other hospitals, in the ambulatory setting. And the keyword, I think, is networking. And we need to ensure that all of these colleagues are aware of where the patient is at when the patient moves from during the transition. So when should we do that? Usually when the patient is ready, usually around age 18. And I know there might be some discrepancies and differences from one country to another, including within Europe. So we need to make sure that the patient is autonomous enough and ready, and also that the parents should be ready as well. If there are several affected siblings who are close in age, maybe it's a good idea to transition them together. If there are developmental or neurological issues, might be interesting to discuss what is more appropriate, and trying not to transfer during an acute complication or via the emergency room. So as it was mentioned earlier, there were a few papers published in this topic in our field. There are overarching principles for transition. It is critical to ensure appropriate long-term follow-up for patients. It is critical to ensure best management of clinical issues persisting throughout childhood and young adulthood, and also that the care of patients should include shared patient-centered and family-centered decision-making with a multidisciplinary team. A survey made by the American colleagues showed that there might not be a transition policy for all centers, and there are still yet unmet needs. And as Shimon mentioned, we performed an ERN RETA survey that showed, including for PIDs, but also for autoinflammatory diseases, that there are defined transition processes for a certain number of conditions, but not for all. For example, for PID, only 44 out of several hundred have a transition process defined. and it's unlikely for PID to have an access to national disease-specific guidelines for transition. So there are weaknesses that were pointed thanks to this study, and most of them were fragmentation of adult services, lack of holistic approach in adult care, including psychology, and I think we will mention that during the topic, but also happens in pediatric care as well. One major issue is lack of resources and funding from transition, and we can discuss the necessity to have a coordinator of transition, for example, and time to properly prepare the documentations is crucial. It is really time consuming, and probably lack of suitable centers to transition to could also be an issue. So just to summarize and finish, it is really important to remember that we want the patient to be a fully developed and let's say happy human being. The process should start early, probably around 12, 13 years old, should not stop at the transfer point, but continue during the adult. We should mention the role of the parents and the caregivers and also the primary care provider. It is also a crucial time, an ideal time to rethink diagnosis and management, for example, genetic diagnosis, but also psychological potential issues, and go beyond strictly medical issues, as patients have many transitions happening at the same time, moving from one town to another, integrating university, for example. So it's quite a challenge for many of them. Thank you very much. Now, I think we would like to hear from a patient, really. And it's my pleasure to introduce a patient who lives in the Netherlands, Amy van As. Thanks, Amy, for joining us today. You sent me a short biography, so I will just read what you sent me. And your name is Amy van As, and you're currently 19 years old, and you still live at your home, a family home, with your parents in the Netherlands. And you got your teaching assistant degree last year, and now you are studying occupational therapy. So thanks again for joining us today. Could you let us know about your personal experience? You know, what is your PID, for example? How were you diagnosed? How, did it take a long time? What were the hurdles? Do you really remember some things regarding this, and how you were managed and how you are currently managed? Just to start, with a more in-depth presentation of yourself.
Well, I got diagnosed with CVID when I was 12 years old. Before that, I approximately spent 6 of those 12 years either sick at home or in the hospital. On one side, it was a relief to get a diagnosis because you know what's wrong, what is going on. But on the other side, it got very real for all of us, for me and both of my parents. The most common symptoms I had before immune globulin treatment were multiple pneumonias a year, respiratory infections, and ear infections every year. I also had a lot of skin rashes, eczema, intestinal problems, and extreme fatigue. After the diagnosis, they started giving me with monthly intravenous immune globulins. This gave me a lot of complications, and I got very sick that afternoon. The nurses at the regional hospital just weren't educated very well about the diagnosis, the treatment, nor the possible side effects. They did not step in when the first side effects started showing. After that, we went to another hospital where we tried some other treatment options. They first gave me monthly subcutaneous immune globulins, but they also made me very sick. Let's say that if I got my immune globulins on Friday, I was extremely tired on Saturday and Sunday. On Monday and Tuesday, I had migraine. And on Wednesday and Thursday, I had to recover, which basically means that I missed a whole week of school. upon all the times I was sick already. So it just wasn't a big improvement. The last treatment we tried was weekly subcutaneous immune globulins, and they luckily caught on. Getting immune globulins just doesn't solve all your problems. First of all, the search for a treatment that fits your body and fits your lifestyle can take a very long time. And second of all, I still have all my symptoms, not as often or as much as it used to be, but they are still there, and I know they will never go away, which is why I find it very important to not only tell this and tell my story to doctors, but also tell it to my friends and family so they can understand that why I am maybe not able to go with them on Saturday and Sunday, but that I have to choose.
Thank you so much, Amy, for sharing this, and that's very illuminating. I forgot to mention that our followed up in Rotterdam, Erasmus University Medical Center, and that Dr. Virgil Dan, who is on the webinar as well, is currently your PID specialist and treating physician. Regarding specifically transition, could you let us know what your personal experience is?
My experience of the transition care is that it was actually very pleasant to me. Everything went gradually and in consultation with me and both of my parents. When my transition care started, they introduced us to the Ready, Steady, Go. And they gave us 2 lists, one for me and one for my parents. And there were a lot of categories, and every category had questions, which you could answer with yes, no, and I want to know more. I had to fill in that list every time I had an appointment at a hospital. And the first 2-3 times I thought it was very helpful. It gave me an opening to ask questions about topics I had maybe been avoiding because I was too afraid to ask them, but also topics and questions that I had never thought of before and never thought of asking. So it was very helpful. On the other hand, it did feel very long-winded for me because at some point I felt like the questions that I had were answered, and I didn't really feel like the other questions that maybe weren't really answered were helping me to grow. When I'm looking back at the transition care, I feel like they maybe could have started a little bit earlier, because in my case, they started my transition when I was 17. For me, that was a lot in a very short amount of time. I mean, I have had a lot of doctors over the past few years, and I personally like to get used to something before having to do something and having to go to someone. So giving me a little bit more time would have helped me to go into that a little bit more relaxed and get to know the ID and what I had to do there.
Thank you. Really very, very, very important thing that you mentioned to us today. Can you maybe also share a little bit with us a little bit of what you think your parents went through?
Yes, I can. My mom gave me like a little story that I'm gonna tell, that I'm gonna read. So she wrote, Amy got diagnosed with CVID when she was 12 years old. The previous years were very tough for me, her, and my husband. She had a lot of pneumonias, respiratory infections, ear infections, skin rashes, eczema, intestinal problems, and extreme fatigue. But if there's no diagnosis, there is a lot of resistance from school and also the environment. The first treatment with immune globulin was in a regional hospital and did not go well. She had a lot of complications and got very sick. Her body simply couldn't handle the sudden overdose of immune globulin. The general practitioner referred us to the Erasmus MC Sophia. Being treated in an academic hospital was a breath of fresh air, a clear explanation about the disease, good treatment, and always somebody to reach out to if needed. That was what we needed all along. After a long search for the right immune globulin treatment, it finally caught on. Amy still had a lot of respiratory infections, but now it was monthly, not weekly anymore. The fatigue became less, but it's still a big struggle. The transition care was very pleasant. We, as parents, got involved in every step of the way. They mainly did this via question lists. This was very helpful to give Amy more control over the process. From the beginning, she was involved in every decision that had to be made regarding to her health.
Thank you so much, Amy. And I think it was really great to have your experience shared with us today and with the public. And I think there might be many questions during the Q&A at the end of the session. Is it now my turn to hand to you, Siobhan, or?
I think you could go ahead, Nizar, and
Right.
introduce the speakers. Thanks.
Okay. Pere Salaire, everybody knows you, Pere. You're a pediatric immunologist in Barcelona, in Catalonia, in Spain, and head of the Pediatric Infectious Diseases and Immunodeficiency Unit at the Hospital Universitat Vall d'Hebron in Barcelona. You're very much involved in the transition care in your center. And yeah, we're very happy to have your expertise and experience and insight. Thank you.
Thank you very much. It's a great pleasure to be here, and even more after this inspiring talk by Amy. What I will try to do, just can you see my screen? Yes, okay. So what I'll try to do is try to share with all of you our perspective from the pediatric side, and how we are trying to manage this transition process in trying to make it as smooth as possible. And it's great to hear that when you do the job the right way, like our colleagues in Rotterdam, it works, like Amy told us a few minutes ago. So that's how our program in the hospital it's organized. It's focused both at children, teen, and young adults, because as Nizar said at the beginning, it's not over when a transfer is done. So you still need to work after that on transition. It is obviously a multidisciplinary process, and there are a lot of actors there. But at least in our hospital, the coordinating one is the nurse. I mean, a practitioner nurse is key in the development of this process. Obviously, there are transitions of different complexity depending on the disease, but it's also true in primary immune deficiency, depending on the patient that you are that it's under transition. We mainly transfer our patients to our adult units in the hospital, but it's true that since we are a reference hospital, we are sending few of them, to other hospitals in Catalonia and Spain, and there's a shared follow-up with primary care also for the adults. It's even more common to receive teenagers from our hospital joining our adult services, mainly in primary immune deficiencies. Obviously, this individualized care that has been mentioned before. We are also using telemedicine and other technologies and try to help our adult patients who have been transferred to other hospitals. And we are listening to our patients through our patient associations and foundations. And this is not only true for primary immune deficiency, but for all mainly rare diseases that we are following in our hospital. We are a reference center in primary immune deficiency in Southern Europe. You all know that. We are now following more than 1,000 patients, half, let's say, with children and adults. And what we did with this, which is called SOMI project, it's called Let's Go. we adapted that to every single disease, and that's what we did in primary immune deficiency from 2021. We are transferring around 6 to 8 patients every year to mainly to our units, as I mentioned before. And as I said, we do have psychologists, we have social workers, but we mainly have this practitioner nurse who is coordinating all the process and listening to our patients. What we try to do at that time is trying to identify the problem from the patient, the family, which is extremely important, not to forget about the parents once you have performed the transfer, also other healthcare professionals. And what we do is prepare, then plan, and then we implement. But we all know that it's a change process, and it's not that smooth as we want them to be, and sometimes has resistance, chaos, and then you get integrated in this new protocol of and this kind of different procedures that it's done in the adult hospital. I'll just talk about the pediatric side. We are now 3 pediatric immunologists. Obviously, they are all the specialists taking care of our patients. There's a nurse practitioner, psychologist, and a social worker. Here you have the pediatric and the adult nurses in our hospital. I will not talk about the adult side. That's up to Virgil after my talk. And we also have a primary immune deficiency committee that it's meeting monthly, and it's not only but mainly dedicated to those patients who will be transferred to the adult unit in the following month. Depending on how complex the disease is, we are working with a basic healthcare team, the nurse and the physician, pediatrician and adult physician. But if it's necessary and the patient is more complex, then we have this multidisciplinary team and we have these multidisciplinary meetings. And in diseases, and that's not the case for primary immune deficiency, in which you don't have the adult side, then we have a transition team that help us with those more complex patients. What I did to prepare this talk is ask back my team to detect the key points after 2 years performing this protocol, what was the key points in their opinion, and they said that it's starting early, as Amy mentioned, around 12. It's the right way to do it, I think, and we decided 12 because that's what we heard from other diseases. We have experience in HIV-infected adolescents a lot of years ago, and they said that they wanted to get all the information before around 12, and that's what we adapted for our patient too. Obviously, we need to adopt a transition to our patients' social reality. We have a lot of immigration here in Catalonia and in Spain. It's key to have the joint visit with the adult and pet specialist. Again, the role of non-physician health professionals and mainly the nurse I mentioned before. We do have this multidisciplinary committee approach mainly for these more complex patients. We need to have this local, national, and European guidelines, and Siobhan will talk about that at the end of this webinar. And we do listen to our patients, not only for creating all the documents, but once we have started with that, we need to hear about their experience. That's why we have their PREMs and prompts, and we have created a lot of supportive documents. I would just comment on these 3 points that I signed it on the left side of the screen. As I said before, we're starting at 12, and that's the right way to do it when you have the appropriate diagnosis at 12. Because I mean, if you are just finding what the patient is having at 12, obviously that's probably not the right moment to start with transition. Though we all know that from a theoretical point of view, that's the best way to do it. It's not always easy because you can find some resistance from the parents in terms of starting talking about transferring the patient at some point to the adult unit when he or she is that young, but that's the way that we are managing it now in our hospital. As I said, we do have different complexity levels of the transition process. Most of our patients are here on the 3rd step with patients of high complexity with all this multidisciplinary team, but even some patients are even more complex, and that has this very high complexity where you have complications to your primary immune deficiency, and depending on the complexity, we decide the number of physicians that need to be involved. And as I said before, we created a lot of documents. We created a dissemination plan, both internal and external one. We work with our internal ICTs, and we have this a transition team to help in case that you don't have the adult side well covered. In terms of documents, as I said before, we have these questionnaires, these plans for patients, always actively asking them if we're doing the right things. We do have this protocol, which is in the next slide, which is in Catalan and in Spanish, and tries to harmonize that we are doing transition for all rare diseases in our hospital, despite this can be adapted to every single disease. And what we created, and I think it's quite helpful, that's available also online. We have information for the adolescents, we have information for parents and caregivers, and we have information also for young adults, and mainly to let them know what they will find when they are transferred to the unit adults. That's in Spanish and in Catalan and too, and have a lot of information for them that can, it's not only giving them those leaflets, but sharing them all the information, allowing them to come back to us with all the questions. But our feeling is that they are really helpful. And that's it from my side. I'll be happy to take your questions at the end of the webinar. Thank you very much.
Thank you so much, Pere. That was very enlightening, very nice. And I think we will probably learn a lot of complementary aspects from Virgil, who he works in the adult care setting in Rotterdam, in the Netherlands, head of the internal medicine unit in the Rotterdam Erasmus MC. Thank you, Virgil.
Yes, thank you, Nizar, for this introduction, and thank you for the opportunity to participating in this webinar. And I was really getting a bit nervous because I was listening to Amy, and her English is so much better than my English at that age. Is remarkable. You really did a great job, Amy. Yes, I'm an internal medicine doctor at Erasmus Medical Center in Rotterdam. And today I would like to discuss, after this beautiful introduction by Pere, how it works from the pediatric side, how we experience transition. And I think it was already nicely mentioned by Amy that I think there's still a lot of room for improvement for transition care, also from the adult perspective. And I think why is transition important? And it's, I think, already mentioned before as well, that due to improved therapies, our patients with primary immunodeficiencies tend to live longer in good health. So we have to take care of them for their whole life. And this slide was already demonstrated by Nizar, and I think this was actually one of the basics that I started working with. Why is transition care so important for primary immunodeficiency patients, but I think for patients in general, because it is very important to have good transitional care to ensure long-term follow-up of these patients, to get those patients attached and adherent to your care. And I think it is important to ensure the best management of all clinical issues that start at childhood, but of course progress during all ages. So when I'm thinking about transition care, I think there are specific topics that we tend to think about, tend to address. Like Amy mentioned, she started her transition care at the age of 17. So this is the first Red Cross, because like Per demonstrated, I think the age of starting transition care should be much lower. And I think indeed should be around the age of 12 to start children with their transition towards adult service when they become 18. So I would like to discuss some aspects from our Erasmus Medical Center point of view. So we are treating around 750 adult patients with primary immunodeficiencies and approximately 150 children with PID. And this is all within the center, which is a collaboration between the Department of Internal Medicine and the Division of Allergy and Clinical Immunology, where I'm working in collaboration with the Department of Pediatric Immunology and Infectious Disease, where the children are seen and treated. And we have a Department of Immunology, which is involved in diagnostics and research. So one of the questions, how do we do transition care at current in our center? So when we look from transfer from Department of Pediatrics to the Department of Internal Medicine, we have these dedicated outpatient clinics for transition care, which we do around 4 times or 4 days a year. So we have a full day or full afternoon of outpatient clinics, fully dedicated to transition care. So we only see those patients that are in their process of transitioning. Now, every year, over the past 2 or 3 years, we transfer approximately 10 to 15 patients every year from the Department of Pediatrics to the Department of Internal Medicine. And prior to transfer, there are multidisciplinary meetings to discuss all the patients and the clinical medical history and the outstanding questions, for instance. So these meetings are during their, let's say, transition process, and the transfer is around the age of 17 or 18, actually. So these combined outpatient clinic visits, who are involved, well, the pediatric and adult immunologists, pediatric and adult pulmonologists are involved in most of the patients. So I think the majority of patients with primary immunodeficiencies, in particular antibody deficiency patients, at the younger age, visit both an immunologist and a pulmonologist. And in that case, we also involve the adult pulmonologist in transfers. And of course, we have a pediatric and adult nurse specialist who are very important in coordinating transition care and transfer of these patients. Those are also involved in the combined outpatient clinics. In bold, I put a psychologist, social care worker, rehabilitation therapists. Those are my wishes still for the future. We have some dedicated psychologists, social care workers who are involved in treating and guiding these patients, but we still have some problems with really getting them involved in transition care. And I will come back later to the issues that are involved in that. So in practical, we have, for most of the patients, we have 2 transfer appointments. So transition care, of course, involves a lot of years, but at the age or in the year when patients turn 17, we have 2 appointments. First, in the pediatric hospital with the team seeing the patient in their hospital where they are treated. And then the second visit, most of the times it's 6 months later, we see them with the whole team in the new hospital or in the new division of internal medicine. So that's the actual transfer around the age of 17, with this team involved before and after the transfer. So how is transition performed? Well, this is actually the example that Amy mentioned, and I think it's one of the examples, and this is what we call the Ready, Steady, Go transition tool. It is a general transition tool developed for children with a chronic disease, so not specifically for primary immunodeficiency patients, but can be used for any chronic disease. And it's a tool in which, like Amy explained, questionnaires are developed and provided to the patients to see whether they are familiar with the disease, know their treatments, or are they ready to be responsible for their own disease and their own care. Are they steady in a certain age? So are they stable? Are diagnoses put together? Is the treatment stable? And then there is the go for transfer to the adult clinics. So this is a program that runs from the age of 12 to the age of 18 to get those kids ready for transition care and transfer to the adult clinics. But this is just an example which can be used in clinics, but I think it's still requiring improvements. And I think national or international guidelines or advices are very useful, could be very useful to improve transition care for these patients worldwide, or at least in the Netherlands to start with. So one of the important people, in my experience, in transition care is our nurse specialists. So she's specifically involved in patients with primary immune deficiencies. So she in general coordinates the care for these patients in the adult clinics. She sees those patients at outpatient clinics. She is important and also responsible for the immunoglobulin replacement therapy treatments, involved in development of care path. And I think one of the important topics of her daily job is transition care for these patients as well. So the nurse specialist is truly one of the coordinators of this transition care. So we use this model of this Ready, Steady, Go tool to get those patients ready for transfer. And I think very important is also what do these patients expect from us, or what do they want from us? Because I think we feel that inadequate transition may result in loss to follow-up. We have had several examples of patients that if you don't get them attached, they will not show up at your outpatient clinics after transfer. So there is also reduced adherence. People stop using their medication if they don't feel attached. And there's a lower grade of satisfaction of care if transition is not appropriately. So in Erasmus Medical Center, there is this board of patients, which consists of 15 patients in the age of 40 to 24 years of age, who are involved in developing, improving transition care. So they have their input. What did you experience? What would you expect? What did go well? What did go wrong? What should be changed? So it also gives important feedback from these patients. So with that help and with the teams involved, the transition care teams from Erasmus Medical Center, we try to develop a kind of a blueprint for transition care, which exists of 3 phases. So the preparatory phase, getting them ready for transfer, then the actual transfer. And I think one of the important issues is also care at the adult unit. So what we call aftercare, because transition doesn't stop when people get 18. You also have to get them attached to you, because they are in a new environment. They have new responsibilities. We are not talking to the parents anymore. We are talking to the patients themselves. So a lot of things change, and change is you have to take care of that. That change doesn't mean that they will stop coming to the outpatient clinics. So in that sense, coordination is crucial, and a nurse specialist is, I think, very important in that. So this is just a schematic showing of what I just discussed. So we have this pediatric team on the left side, the multidisciplinary team, which adds the pediatric team to the adult team, which are all responsible for transition care, where we have actually 3 phases: preparation, so get a transition plan, prepare the parents, prepare the patient for transfer, let them meet with the adult physicians before transfer. Then the actual transfer, do it together with the pediatric team and the adult team. Take care of the documents, that are those all in places. What kind of documents are needed? Think about, for instance, insurance, because when you are 18 in the Netherlands, you have to get your own insurance, because otherwise your care will not be reimbursed. Small things, but very important for patients to think about when you transfer those patients. And also when they are in adult care, think about how to arrange these initial appointments at your outpatient clinic, because we tend to have 10 to 15 minutes for a patient. But when you have a new patient who got transition or transfer from the pediatric department, you won't make it in 10 to 15 minutes. You will need some additional time for your consultations. And it's nice to think, and it's nice that you want to do it, but the problem most of the time is also what we experience is not reimbursed by insurance companies. So there's always a difficulty what you want and what you cannot do. But those are things that we also think about when we try to get transition care better. So some outstanding challenges that I experienced. One of the issues that we experience ourselves, it's reimbursement, because we want to do these joint clinics with the pediatric team, with the adult team, but it's very difficult to get the reimbursements for these joint appointments, because who gets the money, so to say? You invest time, but it's not reimbursed. And as a doctor, it's not of interest maybe, but my board of directors always ask me, what are you doing? Because you are caring for patients, but there is no money. So that's something that we should think of. specific issues with reimbursement for instance, psychologists is something that we are fighting for. And of course, you need specialized and dedicated staff within both departments. So you really need people who are dedicated to transition, not only an immunologist, not only pulmonologist, but also gastroenterologists, dermatologists, because these people, or these patients, have a lot of specialists taking care of them. Patient adherence and aftercare is very important after transition, but I think that Marianne will also address these questions in more detail. So with that, I would like to end my presentation, just giving a brief overview of transition care from, let's say, an internist point of view. Thank you.
Thank you. Thank you so much, Virgil. Very nice to hear all of your experience at your center and the point of view from the adult part of the pathway. And you mentioned the very crucial role of specialist nurse. And I think it's time for us to hear from Elizabeth, who's a referent nurse in the UK, a member of INGAID, and who's very knowledgeable and very knowledgeable in the field of transition in the PID. So hand over to you, Elizabeth. Thank you.
Hi, thank you. So I'm a paediatric nurse in Oxford, and I'll just give you a bit of an overview of what we do here. And really, it's more the gaps that have become apparent through healthcare transitioning process. I've been working there since 2014 on a day a week. Our patients come under the paediatric infectious diseases team and a clinical immunologist. So our patients have the luxury of knowing the clinical immunologist as pediatric patients and moving into adult care. We do have input from Great Ormond Street, from Austin, every 4 times a year. I am the main link for the PEDS patients, so they will email me or call, and I will call them to clarify issues. I make every effort to spend as much time as I can with the families, so I do all the subcut immunoglobulin training, and will attend anything I can when I'm about. And then with patients, I will help them through clinic and their parents asking questions that maybe they've emailed me. So I kind of communicate and help facilitate that. I oversee their home care. And our team is implementing what we learn more and more into everyday practice, but with healthcare transitioning, timing is the issue. But these are my learnings from healthcare transitioning, how I've interpreted them. So Amy may have different views, but I hope I'm speaking for my patients. But our key is to, my belief is our key is to educate the young people to tell their own health story, having addressed all the issues that arise from this by the time they move to adult services, which is pretty impossible, but that's our aim. This includes a relationship with their bodies and the medical team and the medical trauma we've inflicted upon their bodies. This includes their feelings towards their parents who've allowed this trauma to happen. This includes the parents' fears after their desperate fight to obtain a diagnosis for their child, find peace with this fight and trust the initial team that saved their child, and trust that this isn't the only team that is going to invest in the future as their child grows up. It includes helping parents letting their child become independent in their healthcare, and includes helping parents become parents and relinquishing the medical caregiving role to their capable grown child. And I think we've realized that though the process of transitioning starts at around 12, this support of the child and the parents needs to happen from day one. So I've started to keep a list of the child's chronological events so that we have this health story written down when they reach adolescence, so that I can constantly remind them of when they last had an infection or when they started treatment. So it's been really helpful for us to refer back to who they're, because we're a tertiary centre, we get patients coming in from hospitals at their main district hospital. So we provide them their sort of overview of their care so they can keep sharing that with the people that look after them. I think a lot of everybody, health professional wise, wants to healthcare transition, but time is a big stopping factor. And we also need to become expert in adolescents and their health, and we need professionals to lead on this. Universally, all the evidence is showing that healthcare transitioning remains ad hoc, and we are under-resourced, and we are therefore failing this age group, which are still worldwide the most under-resourced developmental age. Adolescents and young adults are entering their adult service unfamiliar with their specific condition and history, unaware of their psychosocial needs, and the parents who fought all their lives for their children are being asked to step away. In paediatrics in the UK, we tended to use a family-centred care approach, but now because our parents are providing most of the medical therapies at home, therapies that most clinicians wouldn't know how to do, this is starting to impact on their relationship with their child and can create conflict at home. So there is a move now and research being done into a more child-centred care with support for the families as an extra, a very important extra. So adolescents with a chronic health condition are likely to have a greater risk of mental health disorders. Psychological outcomes are rarely reported and also not really included in the healthcare transitioning tools from my experience. We inflict this trauma as health professionals, and we need to be aware of it, recognise it and manage it as it happens. Parents often fight for the diagnosis, but they also have to agree to sometimes life-threatening interventions, agree to complex medical intervention training, and they have to negotiate with their child to deliver this at home, often being done at home just to ease their own pressures of coming into hospital. And parents often will say to me that they are responsible for the medical decisions that have been made. So I think we need to look at our language and when we're consenting patients to medical treatment, so that the parents are consenting to the experts and not actually, I think, left feeling responsible for the decisions that they make. This is all from feedback from parents. One of our parents said to us once that it was easier to watch a child have 2 cardiac arrests than watching them come to terms with their primary immune deficiency and everything that entails. And I think that just indicates the trauma that parents really are left with. And we cannot forget we have a term now, the glass children. These are the siblings of children with a chronic healthcare condition. And I think, especially if a child dies, these children really do need our input as well, and to be in a way part of a transitioning process, because we've brought medicine into their home. So I think we've noticed the impact on the siblings as well. The next slide is some of the tools I've been using to try and address emotional health of children at the time, and they proved really helpful. We had a psychologist for a year, but she's had a baby, so I work really closely with them. So we found that actually we need to bring our own psychological support into it. Mark Brackett, we use this colour diagram in schools a lot over here, and it's learning to recognise which emotion you're feeling. But I found this mood meter really helpful for a little girl who had HAE, who was dropping out of school a lot, being sent home from school, and I asked her how she feels when she has an HAE, a true HAE attack, and she, on the y-axis we have energy, and she said she feels low energy and it doesn't feel nice, which put her in the blue zone. And I said, when she's at school sometimes and they're sending her home and she doesn't think it's an HAE attack, what's her energy like? And she said it's very high and it doesn't feel nice, and it was more in the red zone. So that was really helpful in terms of her trying to distinguish between her own health and her own anxiety related to it. She's 8 at the moment and is using that really effectively. Heads model is something that's used quite a lot in this country. I have to say I haven't really used that much, but I will. I'm planning to. It's quite hard on 1 day a week. Always I will ask patients before I start a procedure, out of 1 to 10, how happy are you for this procedure to happen? 1 being horrible, don't want it to happen at all, 10 being fine. And always at the end, I'll say, how was it on a scale of 1 to 10? And it's really helpful because they'll often really notice that actually it's much. I've had a 0 to start with and a 10 to finish. And so when that child comes back in, that's incredibly helpful for them to realize it wasn't as bad as they thought. So we found that really helpful. The next slide is, we've had to do a crash course in working with adolescents. I've worked here for 20 years and I've always liked working with adolescents, and I work in schools with adolescents. There's a brilliant book at the end, which is a great overview of the teenage brain and this developmental age from 11 to 25, and how the brain changes we can work with the brain changes to enable us to help teenagers. But initially, we all thought that teenage years were hormones. Most adults don't really look fondly back at that traumatic time of teenage years. But actually, we can work really well with teenagers. And I still work in schools. I still work with the teenagers here and find it's really helpful. So risk-taking is part of moving away from their gene pool. So they need to leave their family home and form their own herds. Dopamine levels, our happy hormone, are lower in teenagers. So to get that up, they need to take these risks. And we need to support them in that and be aware that those risk takings will perhaps happen. And they need to be able to talk about this with us as healthcare professionals, so that they're not hiding if they're maybe missing out on medication or not wanting to engage. We need to be aware that they what is so key to them is that they are accepted by different groups that are outside their family, and they are highly sensitive to emotional stimuli and hypersensitive to peer rejection. And I've come up with some top tips that we've found have been really helpful in working with teens and getting these sorts of gaze. So we're on to the next slide. So employing tactics that adolescents are programmed to value has been key. One of the things that was really interesting, there was a study that said a neutral face is deemed as hostile. So with that in mind, we always need to smile and welcome teenagers in. And it's really interesting, when I start school talks, I'll often ask them what I'm thinking, and I'm usually thinking my washing's on the line and it's raining. And but they all say, you hate me, you know, that they're reading this blank expression as against them. So we need to be mindful of being friendly. We need to connect. One great tip of gaining connection is to look someone long enough in the eye to establish their eye color. We will be judged in seconds. We need to be honest and be human. And I think in clinics, it's really interesting when I leave the room with patients, they will often critique the doctor who has spoken to them and say what was good and bad to me. Shaming a patient by asking them a question that doesn't make sense to them, or they feel they're not answering it in the correct way, and causes them to lose face in front of a team. Shame is linked to feeling defective of themselves and feeling helpless. So we need to explain until they understand. And if they don't understand, that's our fault. We need to make things easier for them and just allow them and facilitate this asking of questions. And that's what nurses' roles are, I believe, in that we can sort of keep helping them and training them to challenge. Mirroring, we've started using in babies. This has come from feedback from patients. But if we are pinning a child down to have a blood test and they are fighting us with everything they've got, and we're saying, good, well done, you're being really brave, we are not recognizing their emotions. And for a patient to feel safe, they need us to be able to recognize that we see what they're feeling and to acknowledge that. So actually mimicking their expressions and actually saying, I can see that this looks hard for you, and just trying to help them explain how they're feeling will help them feel seen. And then also empathizing with them at the end so that they know that we do care, and making them feel secure and safe is what will gain trust and what will eventually with all our patients equate to a good outcome. And just to make us feel better as health professionals, our teenagers that we have here know our lead doctor from childhood and they still disengage. So it isn't just about us, it is to do with their development and it is to do with where they are in life. Scenarios I found have been the best way I've ever had to teach teenagers, both in schools and in the healthcare profession. And we had a patient that was going to a music festival. She's not great at taking medication. She was going to be eating from stalls where we were worried she would eat food that might trigger infection. So we were giving scenarios like, well, what happens if you get sick? What happens if your phone's died? So you're walking them through the worst case scenario. And hopefully that will be of help as they get older. boundaries are still important. I don't know if Amy would agree with this as when you were younger, but actually when they've researched boundaries at university level with students, those that didn't have boundaries as children were actually quite filled with shame, because boundaries equate to somebody actually caring about you. So we need to have boundaries and be able to implement them and support parents, because parents are at home administering health medication that we would normally give in hospital and probably give more easily because patients are coming into hospital. But in the home place, we have parents that are tiptoeing around their children. I've got one mum who says she sneaks his needles in whilst he's watching telly. Hopefully he doesn't notice. So we need to be able to enable parents as well to establish boundaries. Peer support obviously is brilliant, but again, as teenagers, if you're introducing them to a herd that they will be self-conscious at joining, we need to be aware that we have to do that either as part of their care, which I liked. I think it was Virgil saying that they have a clinic, or a transitioning clinic, which is where they have to come, and then they're forced to meet other teenagers, and that's where I think their specialists could run events that would be helpful for that. And the last slide that I'm talking about, I've got some links on the other side, is a quote from Maya Angelou, that I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And an ear that shows its listening is an intervention in itself. Even if we don't have all the answers, if we acknowledge young people, how they're feeling, and they are allowed to express that without feeling shamed, we support them through that and make them feel safe and secure, both the parents, the children and the siblings, then I think that is the best we can do. I've put some QR codes up on the next few slides for some of the other frameworks that we use here, or that are available. And then the next slide, I know the slides are being shared, is just some of the books that are. Brainstorm is Dan Siegel's book, which really explains the joy of working with teenagers. And then these are quite popular fiction. The Sarah Jane Blakemore's is just about the developmental brain. And then The Body Keeps the Score is the effect of trauma on the body, which we've been using a lot to try and help young people, both in schools and in the hospital. The last slide is key for the ESID is the nursing group that supports all our colleagues in nursing, and we've got an amazing group of nurses that we link into all the time. Our funding is available for ESID in Marseille, for ESID, the nursing group, and there is a Professor Imelda Coyne from Dublin who's coming to do a talk on nursing roles, particularly in transitioning. So I think it'll be really exciting, and if you have nurses that aren't on this talk who would want to join, there is funding for them to come and to network with us. The end.
Thank you so much, Elizabeth, for this very important insight that you gave us today, and how crucial is your role and the role of nurses and specialist nurses in the care of patients, and specifically teenagers. But I think it's time now to hear from Marianne, who is a referent nurse in clinical immunology and internal medicine in Rotterdam, Erasmus MC, on how also the role of nurses in the young adult care setting is crucial as well. Thank you, Marianne.
Okay, I'm Marianne van der End, clinical nurse specialist from the Erasmus Medical Center in Rotterdam. I'm the colleague of Virgil Dahl, and I want to share with you the nurse perspective in transition care. As you can see, I have a nice logo on the right side of the slide. YAP, or Young Adult Program. Advisory board, and the members of this board like the transition care, so they find another more nice name to explain what we I'm sorry. They find together another term for transition care, and that is the young adult program. Go to the next slide. Thank you. I want to start with the timelines of transition care. The transfer starts at 17 years old. We organize 2 joint clinics. The coordination is in the children's hospital. My colleague, clinical nurse specialist from the children's hospital, organizes 2 joint clinics, and the first one is in the children's hospital, and there the young adults can meet the adult healthcare team, and the team is in the team we have of course the medical doctor, Dr. John, and the pediatrician from the immunology, and the nurse specialist from the children's hospital, and from the adult care, and if involved. Okay, I changed from the
sound quality was suboptimal, so it's great if you can yeah, if you could switch. Thank you, Maria, for taking from here.
The first joint clinic is at 17 years old for the young adult, and the second one is if the young adult is 18 years old, and after that we have the double time consultations at the adult care, and so that is only the timeline. And what I want to share with you is that in the Erasmus Medical Center, they start a pilot with a transition coordinator. And we hope to get involved in this pilot over a year. And the transition coordinator organizes the whole transfer, and she starts at the age when the patient is 16 years old, and she accompanies the young adults and their parents during the transition process. After the joint clinics, she will have a meeting with the young adult to discuss the joint clinic, and ask if the young adult is satisfied about the consultations, and she checked if the patient does not lost to follow up, because sometimes we organize a joint clinic and the patient will not show. And also when the patient is 19 years old, she will stay in contact with the young adult to ask their experiences about the transition. In the first joint clinic, it's very important to build trust with the young adult, and the most important goal is preparing the young adults and the parents in leaving the pediatric care. They have to get to know all the members of the healthcare team of in the adult care, but the adult healthcare team as also get to know the young adult. I think it's very important that the young adult can tell us what's important in his or her life, and what he or she wants to share with us, and what's important that we know about this patient. Dus not only the medical care is important, but also we as nurses want to know what the impact is of living with a chronic disease, and in this case with a PIT. It's important that the young adult had to know that we can answer all his questions, and that we can discuss uncertainties. We will share with them and inform them about differences between the pediatric care system and the adult care system. And also, if it's necessary, if there are differences between treatment options in the adult care. Yeah, we want to help the young adult to become more independent, and ask where he or she needs extra help. Very important is that they know how to how to come in contact with the adult care team by phone and by email. And yeah, we also discussed the privacy. That's always possible to come alone in the consultation room with the doctor or nurse without parents, if a young adult want to discuss privacy subjects. But in the first joint clinic, the building trust is is the most important thing of this consultation. Some important differences in adult care is that we have no pedagogical worker. So that means that we can not give them the young adult guidance to, for example, CT scan, or to the extra guidance for by drawing blood samples. We see that some young adults have needle phobia, or have fears for drawing blood or injections. So that is a problem, and for us something we work about to give a better guidance. The telephone contact with the parents up to the age of 16 years will be after that year much as possible with the young adult, and not only with the parents. And from the age of 18 years, the parents are not routinely involved in the communication. Of course, it's always possible, but we first ask the young adult what he or she wants. In our hospital, in the children's hospital, they use an app, the Beter Dichtbij app. And that's very easy to for questions. And in the adult care, we don't have that app. And we work with email. So that's another difference. And one thing what's a little bit funny is that in the electronic patient file, if the patient is 18 years old, then instead of the name, for example, Paul Jansen, it will be Mr. P. Jansen in the file. Yeah. Also, more and more people don't like it to be phoned, so it's sometimes difficult to stay in contact with the patient, because patients like more mailing or apping. In the second joint clinic, we have more attention for self-management and self-efficacy. We will strengthen the disease understanding, and we use the Ready, Steady, Go, Hello 18 questionnaire. The patient can indicate what he wants to discuss and what's important for him or her, where he wants to know more about it. So we discuss the progress in independence. For example, a lot of patients have immunoglobulin replacement therapy, and we want to know if the patient is able to do the subcutaneous therapy fully by themselves, or if they need help for their parents, and if they want to learn it by themselves, or if they have fears to do that themselves, so that we can help in this process to get more independent if it's necessary. We also guide parents in the changing role during the whole transition. If the patient is 18 years old, we ask the patients to fill in value-based healthcare questionnaires about quality of life and fatigue. We give information about that, and we show them that we can follow this quality of life and fatigue dates during all the consultations, and that we can see if they're if there are problems in the physical, psychological, or social care. The pediatrician makes a written handover. I think it's important that the young adults also can tell what's important to write in the letter, what we have to know about him. And we organize a letter to the general practitioner. If the patient is 18 or 90, we organize in the adult care a double time consultation. And then we have time to discuss about the experience from the transfer from the children's hospital to the adult care, and how it's going with the patients and the treatment. And we have attention for the self-management and self-efficacy. And we also ask the patients to fill in the Ready, Steady, Go, Hello questionnaires again. And it depends on it depends of the self-management skills for how many years we ask to fill in these questionnaires, because some young adults is independent at his 19th, and another needs more care till 24. So that we can personalize the care, and we make an individual transition program. What we wish for the future is that we want to evaluate the transition experiences of the young adults and also their parents. We need more guidance for young adults, especially for patients with needle care, needle fear and phobia, and fear for CT and MRI scans. So it will be nice to have a psychologist in a multidisciplinary team. And we have to work on it. We have to have more attention to young people with comorbidities and or intellectual disabilities, because this group needs another approach and more guidance, and we need in this case we really need a transition coordinator and also a psychologist, social worker in the team. So this was my presentation. Thank you very much.
Thank you so much, Marianne. Thank you so much for your insight from the other side of the of these worlds between pediatric and adults. For sake of time, I think we need to move on to the next speaker, who's Siobhan, who will let us know about the activity of the group and the European efforts to provide guidelines.
I was just about to say, I hope I don't drop off, because I have been having some issues with connection. So thanks, Sophia, for sharing my slides. Great, if you could just put them on screen show. Thank you very much. So I just want to finish this afternoon by talking about the recommendations that we've now put together, formal guidelines for transitioning young people with primary immune disorders and autoinflammatory disease. I'm not going to go through all of them. This is really to highlight the fact that these are in the process of being submitted for publication and will be available for the whole community, hopefully very soon. Next slide, please. So just to next slide, please. Thank you. Just to let you know about how the guidelines have been developed for the transition of patients with primary immune deficiency and autoinflammatory disease. This has been a collaboration between the ERN-RITA Transition Working Group and the ESID Clinical Working Group. We have used the standard ERN-RITA guidance for how to develop guidelines, which is to develop an expert consensus using a Delphi method. So we had a group, the transition working group, which was about 15 people, undertook a scoping literature review of literature around existing transition programs and what is best practice. We then drafted recommendations, and the working group reviewed these recommendations and edited them or inputted to those recommendations. Once we were happy with the recommendations that we had, we then developed these as a survey, which was circulated amongst healthcare professionals. And I'd just like to say a big thank you to all of you who completed these surveys, which were central to us being able to develop the guidelines. Next slide, please. So we circulated the guidelines to 229 individuals in multiple centers. We started off with the IPOPI PIDLife Index website. If you haven't been on that, I've put the link there. It's a great website that has got contact details for centers looking after primary immune deficiency and autoinflammatory disease across Europe. We sent mails to individuals at all the centers who had a valid email on that website. That led to 229 individuals, of whom 40% replied. So we had 93 people replied to the initial survey, which represented 68 centers in 22 countries. And we were pleased about this because we're looking for representation across Europe. Almost half of the people who replied were pediatricians, about a quarter were adult people who looked after adult patients, and then about a quarter were doctors or nurses or psychologists who looked after both. We did circulate the survey through the INGAD website and also to a small group of psychologists, but the vast majority of the respondents to the survey were actually clinicians. So we sent round one of the survey now, hard to believe, more than 2 years ago. We then analyze the results of the survey that we got back. We could only accept statements that had a level of agreement of 80% or above into the final guidelines. Anything that was not accepted, we looked at whether the statement could be revised or simplified or changed in some way. We developed a second round survey with these revised statements and sent that only to the initial 93 people who had responded. 2/3 of those responded to the second survey. And again, we accepted anything into the final guidelines that had an 80% or greater acceptance rate. We've now written the manuscript and are in the process of submitting it, and hopefully, assuming no hiccups, you'll see that soon. So I'm just going to use the next few slides just to highlight the different sections that will be in the final guidelines. So there's a section about transition process, and the statements in this section are statements to promote the safe and smooth handover of care to adult services. So things, for example, like the transferring centre should organise formal transition partners, and that the discussion should start before patients are 16 years of age. There are statements in there to help centres to think about gradually building young patients' preparedness, and also to tailor transition programs to young patients' needs. So, for example, young patients should have access to multidisciplinary care to address their multimorbidities. So for different patients, that will mean slightly different things. Next slide, please. There's a section about the administration of transition, which addresses promptly handing over all of the relevant information, and also taking an interdisciplinary approach. So both involving different healthcare professionals and also community resources. So for example, we've recommended that all centres transferring and receiving patients should have a defined transition policy or program in place, that there should be dedicated staff responsible for this who have been trained in in issues relating to adolescence and transition, and that information, including relevant information about things like ongoing clinical trials, should be transitioned with the patient. So there are a lot more statements than I've shown on the slides here, but I have not put them all on today for brevity. So the section about appointments helps us to think about how to arrange appointments in such a way that we gradually increase young patients' involvement in their healthcare. We've recommended joint appointments with pediatric and adult clinicians, and we've put some statements in to help centres to think about supporting greater autonomy through one-to-one consultations. So, for example, we have recommended that joint consultations should be held with parents, patients, their families, and healthcare professionals from both the pediatric and adult teams present for the smooth handover of care. And I'm conscious that that is difficult in countries where maybe the pediatric and adult teams are in different locations, but we need to be trying to have these joint appointments, and that time should be dedicated for these, as some of the previous speakers have indicated. And I think importantly, just supporting patients to understand the need for consent to share information with their family and caregivers, and to provide informed and to think about young patients who are unable to provide informed consent, such as in the event of learning disabilities, and making the correct decisions about how to involve family and caregivers in that following transfer. So there's a section about the content of transition programs, what should be in the transition programs. There's quite a lot of statements in this, but an example here is shown, which suggests that using written and verbal information, the transition process should include education of the young adult on a number of different things, including the nature of their disease, the genetic basis, whether it's inherited, what their treatment options are, what curative therapies may be available, how to manage disease flare-ups, how to manage their comorbidities, disease progression, how their condition will impact important things like sexual and reproductive health, quality of life, vocational planning, etc. So the statements in this section of the guidelines recommend the use of standardized measures like we've been shown today. They recommend personalized and age-appropriate care plans. They recommend offering patients guidance to manage the impact of their illness on their quality of life, and they recommend education on the nature of the illness and its treatment options. There are a couple of other sections in the guidelines I haven't dwelt on today. One is about how we help patients to manage other systems, like, for example, patient support groups, healthcare systems. Virgil alluded to having to put in place, for example, insurance, and also then how to manage and inform educators or employers about their illness where that's appropriate. There's a section on contraindications to transfer of care. So when should care not be transferred to the adult service, for example, in specific circumstances with critical illness or unstable disease, or where the adult centre is not equipped to deal with unstable disease or very severe disease. So what's next? Watch out for the publication, which should be out soon, with full details of all of the guidelines, including in an appendix any statements that the working party put together that did not reach agreement. I think that the key thing, there's no point writing guidelines unless we implement them. So multidisciplinary engagement across medical, nursing, psychology staff, and in fact, hospital institution systems, our managers, for example, to implement the guidelines will be really important. We need better understanding of the experience of patients and their carers to improve transition. And in fact, we didn't involve a patient survey in developing these guidelines. We did have patient representation on the working group, but I think we were actually quite poorly informed in primary immune deficiency and autoinflammatory disease about the experience of patients in transition. There's very little literature out there, and that's something we definitely need to improve our transition processes. So just in terms of thanking people, the work has been done by the ERN Rita Transition Group, but many centres participated in completing the survey, and thank you to all of you who did. I'd like to particularly highlight Muskan Israni and Ilishka Alderson, who were two psychology trainees in our hospital, who put together, who helped develop all the statements and put together the surveys and analyze the survey data, and then the clinical working party with whom this has been done as a collaboration. So I'm going to stop there, and I think, Nizar, we may have a very short time to take questions and answers, as we're slightly over time.
Thank you so much, Siobhan, for this very important piece of work that you've been developing, and you've managed to go to this publication that will be hopefully published very soon with the collaboration of Perry as your co-chair in this transition working group. I think we could probably get a few questions that were put in the Q&A section. And if I may start, because I think some of them are quite interesting to the panel and to the public. One of the aspects that we've seen is that we might have a little bit of a specific pediatric culture in pediatric care setting, and that the culture in the adult care setting might be a little bit different, although we've seen that there are many bridges and many shared points. One question that was asked is, what happens if there is no adult services available, or maybe in a country where pediatric care for PID patients is far more developed? What would you have any recommendations that, because that might happen in some instances?
I mean, I think that the easy answer is just let the pediatrician follow these patients even when they're in the adult age. But it's true that I'm not feeling comfortable when an adult physician is taking care of pediatric patients. So I think that could be a transient solution, but this pediatrician will need to ask specialists in internal medicine, pneumologists, or other physicians to get involved into that, and in a few years being able to create this, let's call adult unit for patients with primary immune deficiency. At least if you have a number enough of patients in a country or a single center to do so. So the answer would be yes, the pediatrician can keep on following those patients for a longer period, but needs the help of these adult physicians, because otherwise my feeling is that the care of these patients would not be as good as it should.
Right, thank you. Probably I might hand over to Virgil to give a complementary point of view, and maybe there are some specifics, because we heard from you, for example, that there is a big issue at 18 in regarding specifically like insurance, and I know that in some countries access to care might be more difficult in patients turning 18 regarding, for example, IG replacement therapy. So what do you think about that? Because as members of the ERN, we might also have some guidance in these settings.
Yeah, so I think if there is no specialist in adult PID available, like Per said, then I think maybe you should consider a pediatrician taking care of an adult patient for the sake of time. But I think when these patients get older, they also get, let's say, non-PID related complications, which are different between children and adults. So I think the older they get, the more, let's say, adult-specific diseases or complications, and even non-PID complications may occur. So I think taking care of older patients is getting more and more difficult for pediatricians. So I think we really should strive for adult specialists for PID. Yeah.
Thank you very much. Siobhan, you raise your hand.
Yeah, I mean, I think it's a really important question, and I think that although centres have everywhere will do a workaround, won't it? Because we want to look after our patients as best as we can. But I think that it's really important to try and collaborate with adult specialists, even if there isn't somebody specialised in the area. Somebody who's keen and amenable to learning can be a good collaborator to have. And I completely agree that in areas where there's no obvious adult center to transition to, the pediatricians need to work hard to try and establish a transition center. And that might not be to immunologists, it might be to rheumatologists, for example, if that's the most appropriate local center, and there's somewhere that is somebody that is really interested. But I think the model of pediatricians looking after adult patients into older age doesn't work very well, and certainly in the UK the problem arises when they need to be admitted, and then they can't be admitted to an adult hospital after the age of usually 16, but definitely 18. And then you end up in a position where actually acute admissions are being managed by a team who's never looked after the patient. So I think it's challenging, but we do need to find ways to collaborate across and find ways to make it happen locally.
Yes, thank you so much for all of your insights. If I may, allude to something that is related, is the topic of teenagers and young adults with complex needs. I mean, we hear about children with complex needs, but then they grow up and the transition. These can be quite challenging in the time of transferring, so preparing the transfer during the transition period of time in the pediatric care setting. Do you think, I mean, what are the main hurdles and what should be addressed? And for example, do you think transition platforms, transition units, or transition coordinators would be necessary? What kind of profile and expertise? Should they be nurses, psychologists, social workers? Could you what are your experiences in that? And everybody can can join here. Do you think maybe Virgil, if you want to start with some throwing some ideas?
So yeah, I think one of the important things, well, I think it has been passed by during this event, is there needs to be a dedicated coordinator in a way to get transition care, let's say, to a new plan. I think it is key to gather or to get the right people together. So from a medical point of view, a nursing point of view, psychologists. So you have to build their team, and someone has to coordinate building their team. But also you need the resources to get that done. I think that is still one of the major issues. So I think we still have to, let's say, show or prove or to, let's say, governments or policymakers that transition care is important, and it requires investment in time, in money, in dedicated staff. So that's something that we really should work on together, and potentially on a national or European level to go to policymakers and show that this is really, really important. Because I think the people who are here and who are watching this, they are all aware that it is important, and we all feel engaged or dedicated to work on it. But you also need the resources to be able to do it.
Definitely, this is one of the crucial thing that we strive for: time and resources. Maybe Elizabeth and Marion, because what you showed us, you play a huge role in absorbing a lot of what is really mattering to patients, which is usually at this time of period of life, strictly speaking, medical aspect. I mean, they struggle a lot, and especially in mental health. And I think I want to talk about mental health issues. And when we were preparing this with Amy and Virgil, I think that topic really came as very important. So if you don't mind, sharing with us, Elizabeth, Marianne, and also Amy, what you deal with, what is your experience, and maybe with some of tips and solutions you might share with us.
I don't mind going first. I think what I worked for about 15 years at Chiva, which is a Children's HIV Association camp, and HIV had huge funding, but they are the most together patients I've ever met. And when we first went, the first year, we sort of facilitated a bit, but now we're just there to tick a box of being adults, because these young people have just flown with it. And I know funding isn't necessarily there, but we did a patient day here which worked really well, where parents met adults with PIDs, and they found that really helpful, that actually these adults were quite competent, so that gave them hope for their children. But I think somehow bringing families and patients together is it's a really healing thing. It's discussing, somebody else is going through this, they're not so alone with it. And it was incredible, the feedback and that we got mainly from the parents, actually, in our small group, because we didn't have many teenagers. But I think my ideal would be to have a camp that we all go to, just for a few days. I know that may not happen, but it's incredible. The young people have then been forced to meet, they create their own networking, and they feel less lonely. Don't know what Amy would think of going to a camp.
Well, I think mental health is a very important topic that's not talked about enough. And I get it, a doctor has 10, 15 minutes to go through all the physical defects, but just the question, and how has your mental health been, would make a big difference, not only to me, but I know to some other people, because you don't throw it on the table yourself. Sometimes you have to have someone that can ask you that question. And about the camp, I know they do organize it in the Netherlands.
I'll come.
Have you been in a camp or not?
Not yet, but I'm planning to go.
Okay, good. Because I think one of the aspects that we see a lot in publications or recommendations and guidelines is the support of peers, which really can be helpful at this period of time. Well, it's 6:50 CET. I'm not sure we have much longer time to further, discuss this very important topic, which is quite exciting, and we have a lot of potential other topics to do, but we might keep it for another webinar. I think I hand over to you, Siobhan, as you're hosting the Grand Round webinar series, and thank you again for all your tremendous work, and thanks to all the speakers, and special thanks to Amy. Thank you so much for being there.
Great, thanks, Nizar. So thank you to all of you who persisted to the bitter end. For those who didn't, who won't hear this, and for those of you who want to pick up the slides, the recording will be on the ESID website. It'll take a little bit of time to get it there, but it should hopefully be there in the next couple of weeks. And I just want to close with Sophia sharing the last slide, which is just to remind everybody about the next webinar, which is in February. So there are monthly webinars between now and June. And the next one is going to be chaired by Fabian Hauk and talk about immune dysregulation. So hopefully see you all there. And just like to thank Sophia for helping us today with the running things, and also for all the panel members who have who've contributed today. Thank you very much.